Please welcome Paula Lomas, Senior Director of Clinical Communications at the Cystic Fibrosis Foundation.
Hello to those of you online and those of you here in the auditorium. It is my great privilege to welcome you to the final plenary of the 37th Annual North American Cystic Fibrosis Conference. I hope you've enjoyed the past few days of learning from and with one another. And the learning will continue. In just a moment, I will introduce our plenary speakers. But before I do, I'd like to take some time to acknowledge some extraordinary members in our Care Center network. The Mary M. Kontos Care Champion Award is presented to 2 members of the multidisciplinary care team who have made significant contributions in the field of specialized CF care. This award honors the memory of Mary's passion for excellence and commitment to improving the lives of people with CF and their families through exceptional care and advocacy. Having reviewed the many highly qualified candidates nominated for this year's award, 2 rose to the top. Both have had long tenures at their programs, demonstrating a characteristic that is unique in our clinical community by serving people with CF and their families for over 2 decades. Both are leaders on their respective teams and embody compassion and dedication to advocacy and improvement. Our first recipient is described as the cornerstone of the Adult Care Center at Indiana University and has worked there for 20 years. She has mentored numerous care team members, students, and advanced practice nurses. She has been a facilitator of our foundation mentoring program, is a faculty member of the Leadership and Education for Advanced Practice Providers, our LEAP program, and is her team quality improvement lead. She is a dedicated volunteer at her local CF Foundation chapter, even taking a pie in the face for CF. She is a passionate advocate for her patients and families in all that she does. And one of her patients has said, "Jana doesn't quit when there's a problem to solve. Therefore, I don't either." The first recipient of this year's Mary M. Kontos Award is Jana Yeley, Program Coordinator and Nurse Practitioner at Indiana University Adult CF Center. Unfortunately, Jana wasn't able to be here today, but she was able to accept her award earlier this week. Our second recipient has served the CF community for 25 years as team respiratory therapist, program coordinator, quality improvement coordinator. Her love for her patients is contagious, and she ignites that same passion in each new team member as they are welcomed and onboarded. She ensures that her team shares their successes on a national level and is a frequent presenter herself. Nationally, she's been a mentor, quality improvement coach, a partnership enhancement program facilitator, and a representative on numerous foundation committees. Her passion for CF and the mission of the foundation is demonstrated in all that she does. And she is also a strong supporter of her local CF Foundation chapter, never missing a fundraising event. I am proud to announce that the second Mary M. Kontos Award goes to Shaina Blair, Pediatric CF Respiratory Therapist and Program Coordinator at Central Texas CF Program, QI Coordinator at Dell Children's Medical Center. The Carolyn and C. Richard Mattingly Leadership in Mental Health Care Award is given by the Cystic Fibrosis Foundation each year to a member of the CF community in recognition of their leadership and commitment to the mental health and well-being of individuals with CF. This award is a tribute to the Mattingleys and their inspiring devotion to the people with CF through the promotion of emotional wellness throughout the CF community. This year's recipient is recognized for her leadership on a local, state, and national level. She is a mental health provider, educator, and researcher. She successfully applied for and received state funding to grow and support the mental health services at her program, allowing them to address inequities in access to mental health services by directly supporting families with Medicaid. She is nationally recognized as a leader in suicide assessment and mental health screening in younger individuals with CF. She is a member of the Success with Therapies Research Consortium, Mental Health Advisory Committee, and co-facilitator of the Foundation's Mental Health Coordinator Mentoring Program. One of the families she serves has said, "She has been there time and time again for us on this journey as we battle conflicting feelings about our realities." I'm excited to announce that this year's recipient of the Carolyn and C. Richard Mattingly Award is Dr. Emily Muther. Emily is a psychologist at Children's Hospital Colorado and associate professor at University of Colorado School of Medicine. Please join me in welcoming Emily to the stage to receive her well-deserved award. Well, I can't believe that we have arrived to the final session of our conference. Our time together has flown by so quickly, and I hope you've learned something new, that you've renewed friendships and made connections with new members of our community, and that you have had some time to enjoy the beautiful weather here in Phoenix. Some of you may remember that we were here in Phoenix for the 2015 North American CF Conference, but do you recall Plenary 3? It was entitled, "There is no health without mental health." Sound familiar? So you might ask, why another plenary on mental health? A couple of sentences from the recently published World Health Organization's World Mental Health Report states, "In all countries, mental health disorders are highly prevalent and largely untreated. Now more than ever, business as usual for mental health simply will not do." Closer to home, we know that 1 in 5 adults in the US experienced a significant mental health issue in 2021. And in the CF community, mental health remains a challenging issue, not just for people with CF and their families, but also for members of the CF care teams. Our work on mental health is certainly not done, but I am proud to report that we, as a community, have made substantial progress on the goal for integrating mental health into the CF care model. I am honored to introduce our all-star lineup of speakers for this afternoon's plenary. Of note, all 3 speakers have been recognized for their important contributions with the Mattingly Leadership in Mental Health Care Award. Dr. Beth Smith is a professor of psychiatry and pediatrics at the Jacobs School of Medicine and Biomedical Sciences, University at Buffalo, where she has served as chief of the Division of Child and Adolescent Psychiatry and interim chair for the Department of Psychiatry. Beth has chaired the CF Foundation's Mental Health Advisory Committee since its inception in 2016. She is an exemplar of providing compassionate patient care and a role model physician educator. Dr. Anna Georgiopoulos is an associate professor of psychiatry at Harvard Medical School and is board certified in adult, child, and adolescent and consultation liaison psychiatry. She is the consulting psychiatrist for the CF Center at the Massachusetts General Hospital. She serves on the European CF Society Mental Health Working Group, and Anna is the chair of PRIME. That is the CF Foundation's newly formed Mental Health Research Working Group. She is a prolific researcher with numerous publications in the last few years. Shaina Blair is a licensed clinical social worker at Emory University Children's Healthcare of Atlanta. Her experience includes developing and providing psychosocial and mental health services within pediatric and adult healthcare settings. She has contributed to the development of mental health resources, and she is an active member of several CF Foundation committees. You've heard the expression, heart, hands, and head. Shaina embodies all three, but especially heart. She is a warm-hearted and caring person. I hope I've whetted your appetite for this afternoon's plenary entitled, There is no health without mental health, progress, challenges, and hope for the future. Please join me in welcoming Dr. Beth Smith to the stage.
Thank you, Paula, for the kind introduction, and thank you for all your support of mental health in CF care. And good afternoon, everyone. Welcome to Plenary 3, which will focus on the integration of mental health into CF care and research, as well as team well-being. I will describe the Foundation for Clinical Care Practices made possible through partnerships between individuals with CF, their families, and care team centers. Dr. Anna Georgiopoulos will provide an overview of research, including a pipeline of evidence-based interventions and priorities for the future. Lastly, Shaina Blair will highlight how mental health and wellness of the CF care team is connected to sustaining quality care for patients and their families. In 2015, Dr. Alexandra Quintner, Dr. Stuart Elborn, and I gave the first plenary ever to focus on mental health right here in Phoenix, Arizona. I am honored to be back here today to review the progress and encouraging direction towards mental health integration into CF care. It is amazing what we have accomplished in the last 8 years, and this trajectory points to a hopeful future. And these are my disclosures. Everything we have built is based on the foundational premise that there is no health without mental health. Mental health is an integral component of our health and well-being, and it's foundational to our individual and collective abilities to cope with the stresses of life, build relationships, and shape the world we live in. As a second fundamental premise, mental health is important for everyone. It is a universal experience, and most of us are likely to experience one or more mental health problems at some point in our lives. It is our hopes that through the initiatives we will discuss today and the shared experiences that you will hear about, we will move together on a path away from stigma. The integration of mental health into CF care was made possible by the collective efforts of everyone listening to this plenary, including those representing the CF Foundation, the CF community, and our CF care teams. Together, we have made substantial progress in CF mental health. I also want to welcome those of you who are new to CF to join this effort, as the upward arrow towards the future now includes you. I'm going to start our journey by briefly reviewing results from the International Depression Epidemiologic Study, commonly referred to as TIDES. TIDES was led by Alexandra Quintner and was one of the largest epidemiologic studies ever in a chronic illness, and is one of the most highly cited studies in CF. It evaluated depression and anxiety in individuals with CF 12 years of age and older, and parents in the US and 8 European countries. TIDES screened over 6,000 individuals and over 4,000 parents and found high rates of depressive symptoms, with 10% of adolescents and 19% of adults experiencing depressive symptoms, and 1/3 of mothers and fathers. People with CF are 2 to 3 times more likely to report depressive symptoms compared to the general population. TIDES similarly found that people with CF are 2 to 3 times more likely to report anxiety symptoms. And after many years of research in CF, the relationship between cystic fibrosis and mental health is now a well-accepted conclusion. The bidirectional relationship has revealed that people with CF who have depression are more likely to have exacerbations, poorer lung function, a reduced ability to sustain their daily care, and a greater risk for complications. A follow-up study by Dr. Michael Schechter and his colleagues showed that a single elevated depression screen in adults in the US was associated with an increase of mortality, a doubling of mortality over 5 years. Conversely, we know that when a person's health worsens in CF, this can exacerbate depression, lead to worry and anxiety, and impact one's overall mental health. In 2015, these results led to a multidisciplinary collaboration between the Cystic Fibrosis Foundation and the European Cystic Fibrosis Society to form the International Committee on Mental Health in CF. Soon after, there was also the development of a CF Foundation Mental Health Task Force that was charged with providing recommendations on what the foundation should do to bolster the mental health care for people with CF and their families. Screening guidelines help us to identify symptoms and risk factors, provide preventative techniques and early interventions, and ensure appropriate support and treatment in the hopes of reducing the impact of mental health conditions on individuals and their families. The International Committee on Mental Health consisted of a multidisciplinary group of 22 experts from the US and Europe. There was a 2-year effort to review the literature and develop consensus recommendations for identifying and treating depression and anxiety in the context of routine CF care. And with this, we made substantial progress weaving mental health into CF care. At the 2023 Volunteer Leadership Conference entitled Our CF Story, Evolving Dreams, Chad Reedy asked Isabel Stencil Barnes, "What does progress mean for you as we go forward?" Isabel responded, "I'd like to see what didn't happen when I was younger, because we were all so focused on physical survival, and that is a focus on mental health and being able to serve those with CF who are struggling with mental health needs because of the disease, but also because life is hard, period." Today, we are focusing on the mental health needs and have developed and implemented a best practice algorithm for evaluating, diagnosing, and treating depression and generalized anxiety disorders in CF. These guidelines recommend that we screen for symptoms of depression and anxiety at least once a year using the Patient Health Questionnaire 9 and the Generalized Anxiety Disorder 7. The next step depends on the screening score. Supportive care is recommended for those reporting mild symptoms, and engagement in evidence-based psychological and pharmacologic treatments is recommended for those with more moderate to severe symptoms. For some centers, this step includes providing an outside referral. And 8 years after the first mental health plenary at NACFC, where the guidelines were introduced, mental health acronyms like PHQ-9 and GAD-7 are now commonplace in routine CF care. We will hear about advances made in the CF-specific treatment of depression and anxiety in the research section of this plenary. The success of implementing clinical guidelines depends on consideration of a variety of barriers and overcoming them. The Mental Health Task Force considered some of the barriers and made a few key recommendations to best facilitate the implementation of the first ever mental health guidelines. The first was to utilize a collaborative care model to integrate mental health effectively and efficiently. As a key component of this, the role of the mental health coordinator was introduced into CF care teams. Next was the establishment of a standing mental health services committee to oversee and support ongoing activities, and this became the CF Foundation Mental Health Advisory Committee. The advisory committee is a multidisciplinary team and includes important community representatives, and I have been honored to serve as the chairperson of this committee since its inception. The committee has been at the forefront of creation and dissemination of CF-specific mental health resources and also implementation research. In parallel, the European Cystic Fibrosis Society developed a mental health research working group, and you will be hearing shortly about the synergy between these two groups. To ensure that the guidelines could be implemented within centers, the CF Foundation created a 3-year grant in 2016 to bring mental health coordinators to the team. And over a 3-year period, 138 CF programs were funded, and mental health coordinators were integrated into our already multidisciplinary teams to provide annual screening, assessments, intervention, and create referral networks. And with this, there was an influx of mental health specialists with additional areas of expertise, such as sleep, pain, and trauma, to name a few. This facilitated implementation of evidence-based best practices beyond anxiety and depression, and provided an infrastructure and more clinicians to strengthen our mental health research. As part of the Mental Health Committee's 3-year grants, the Mental Health Advisory Committee surveyed all the mental health coordinators every year to learn about their barriers and facilitators to implementation. This drove our educational planning, resource development, and advocacy efforts while identifying new mental health specialists in CF care to be the next wave of educators and researchers. And to highlight just a few of our initiatives, we have developed continuing educational programming with mental health specific courses and presentations at NACFC. This includes hosting an annual all-day mental health special course the Wednesday before the conference. We have also facilitated training in a variety of evidence-based psychotherapies and psychopharmacologic interventions, and have created CF-specific mental health information that's available for providers, for patients, and families on a variety of topics, including depression and anxiety, but also beyond to include procedural distress, ADHD, and substance misuse, and to include important topics such as building resilience, coping, and parenting as an adult with CF. These are available on the CF Foundation's website and also in our resource library. A CF Psych listserv was created for support, on-demand expertise, and to disseminate all the resources we were creating. Our committee also provides direct consultations to teams to assist with implementation, and any team can email us at mentalhealth@cff.org for a consultation. Finally, we have our mental health peer consultation groups. There are 12 groups that meet regularly with over 100 mental health providers. These groups are consultative, have case-based discussion, and promote best practice in screening, education, and treatment. And we believe this type of peer support may help reduce compassion fatigue and burnout. Together, these initiatives have led to improvements in the screening rates for depression and anxiety. The Cystic Fibrosis Foundation patient registry data on screening confirms the success of implementing our mental health guidelines. There has been significant improvement in the rates for screening for depression and anxiety since the guidelines were introduced in 2015. When they were introduced, we were only screening 20% of adolescents and 25% of adults. Our most recent data in 2022 shows we are screening over 85% of individuals with CF 12 years and older. Even fewer individuals were screened for anxiety in 2015, and now these rates are the same as what we see for depression. All the work of our CF care teams and the Mental Health Advisory Committee, together with our grant funding and the CF Foundation support, has led to widespread implementation, including screening and beyond. The Mental Health Advisory Committee used implementation science to provide evidence of these achievements. And here you see the US Mental Health Guidelines implementation data derived from the longitudinal mental health coordinator surveys. Implementation outcome scores were calculated each year for a center with a 3-year grant over a 3-year period. The lighter lines indicate individual trajectories for each program, while the darker green and red lines are the average for the grant cohorts. Implementation of the mental health guidelines was highly successful over time in CF centers, even with diverse characteristics. The main predictor of success was the years of experience of the mental health coordinator on the CF team. And this ties into Shana's section of the plenary as just one example how addressing the wellness of our care team members can be connected to quality care for patients and families. And although both of these arrows show upward trajectory, we know we still have a ways to go. The CF Foundation's strategic plan for 2020 through 2024 included to help optimize mental health and emotional wellness services for people with CF. To help sustain these initiatives and in line with this strategic plan, the CF Foundation added a stipend for mental health coordinators to center grants in 2020. Unfortunately, we cannot talk about 2020 without also talking about the COVID-19 pandemic, which increased mental health concerns. However, we now had mental health specialists on our teams that were able to address new issues such as isolation, fears, and anxieties around COVID. We know there's a growing demand for mental health services and a growing shortage, creating difficulty for accessing services for people with CF, for families, and for care team members who need support. Barriers in capacity of CF teams to provide mental health care and access referrals was exacerbated by the pandemic. Since the COVID-19 pandemic, rates of depression have doubled, and the Surgeon General has declared child and adolescent mental health a national emergency. The next barrier is access. In addition to shortages and long wait lists, there are financial barriers with variable insurance coverage for mental health and limited network providers. There are also racial disparities in our access and treatment. And finally, there is stigma. Stigma leads to prejudice and discrimination against people with mental health issues. And this worsens not only the mental health problem itself, but can stop a person from getting the help they need. Today, together, we are challenging this stigma by speaking up about mental health. And I am so grateful that we will hear personal stories that will help us to overcome the stigma. All of these barriers require creative solutions for people with CF, and having mental health providers as part of the CF care team and bringing in clinicians with specialized expertise is just one part of the solution. Another part is the increasing availability of telehealth. But even with these, we acknowledge there are remaining gaps, and we have more work to do. A survey highlighted how having a foundation of mental health providers in CF was helpful during the pandemic. This graph shows all the responsibilities the mental health coordinator had during the pandemic. Most of our programs continued mental health screening and treatment, although less frequently. Although the rates of annual screening had decreased, there was a pivot to providing mental health interventions, and 71% of our teams were providing interventions. There was also a widespread adoption of innovative technologies to provide services via telehealth, and 50% of our teams were providing individual telehealth therapy sessions, and 10% offered group telehealth therapy. Additionally, our mental health providers began to support their healthcare teams and their individual care team members that were themselves impacted by the COVID-19 pandemic. I have reviewed some of the key implementation strategies to support national implementation of the International Mental Health Guidelines in CF. We are now going to highlight some of the international efforts. Since 2016, the European CF Society's Mental Health Working Group and the Mental Health Advisory Committee have worked effectively together to further our goals, since the challenges and issues we face, especially on the increasing rise of mental health difficulties, are universal. Currently, Drs. Eddie Landau and Sonia Graziano are the co-chairs of this committee and are also representatives on our CFF Mental Health Advisory Committee. We are now going to hear from Dr. Landau, who is a psychologist working at the Lung Center at Schneider's Children's Medical Hospital in Israel.
Thank you, Dr. Smith, for the kind introduction. Today, I will highlight three main areas our two groups are collaborating on. Firstly, the dissemination of clinical materials. A wide range of clinical resources produced by the Mental Health Advisory Committee are available on the European CF Society Mental Health Working Group website. Facilitated by Dr. Anna Georgiopoulos as the liaison US representative, these materials, together with other resources such as the mental health screeners, have been shared with medical professionals and parent associations across Europe, including Bulgaria, Croatia, Slovenia, Estonia, Russia, Poland, Lithuania, Macedonia, Romania, Slovakia, the Czech Republic, and the Ukraine. Many of us from the Mental Health Working Group have either travelled or hosted groups from these countries. In some places, these screening and resources material are the only guides available. These teams have responded with great relief and emotion, expressing how much our efforts are helping them acknowledge and screen for psychosocial difficulties, as well as providing ways to address the problems. As the Mental Health Working Group culturally adapts and translates these resources, we share them in turn with the CF Foundation to facilitate access for members of the CF community in the US who need or prefer to learn about mental health in a language other than English. Secondly, our groups have facilitated an exceptionally high level of peer support and clinical consultations between CF mental health professionals from Europe and the US. This includes formal discussion forums and sharing information on effective treatment approaches. Thirdly, we continue to collaborate on research in order to gather empirical evidence to inform clinical practice. One example is our joint publication on the experiences and preferences of people with CF and family caregivers on depression and anxiety screening at CF centres across Europe and the US. Results from this study show that despite differences observed between US and Europe, there is an overwhelming endorsement of integrating mental health into CF health. Indeed, the results suggest that wherever you are in the world, the act of screening may itself be considered an intervention. It allows for the acknowledgement and identification of mental health difficulties and provides an opportunity to focus on effective ways to cope in order to live well with CF. I've highlighted the wonderful synergy we have created by the close collaboration between Europe and the US. Despite different languages and cultures, we all share the language of mental health and its importance in enabling collaborative care while supporting those countries and communities with more limited resources.
I would like to thank Dr. Landau, who is based out of Tel Aviv and could therefore not join us today, but our hearts are all with her at this moment. With screening of depression and anxiety and treatment integrated into CF care, and with the clinical infrastructure in place, a mental health research working group was established this year to continue tackling some of the community's concerns around mental health. The Prioritizing Research in Mental Health Working Group, or PRIME, is full of experts whose mission is to promote clinical and translational mental health research. The chair of this group is Dr. Anna Georgiopoulos, who I would like to introduce now to highlight advances in mental health research and future directions. Thank you.
As Dr. Landau described, working closely together with our international colleagues has been instrumental in how far we've come in this short time. As Dr. Smith pointed out, however, there's more work ahead of us. In this next portion of the plenary, I will highlight some of the gaps in knowledge that we've identified and next steps to move the field of CF mental health research forward. These are my disclosures. Mental health is complicated, so where do we begin? In 2020, the CF Foundation convened a working group to designate areas of focus for CF mental health research and sought input from the CF community and CF healthcare providers by distributing a national survey. More than 1,000 people responded, reflecting the high interest in mental health. This figure shows the percentage of people who ranked various topics as either very important or a top priority, with community members in yellow and healthcare providers in blue. You can see that there was remarkable consensus between these two groups on the top 6 topics, and you'll hear more about these shortly. However, there were some topics that healthcare providers flagged more often as high priority, including substance misuse and disordered eating, whereas community members were more likely to prioritize the impact of side effects of CF medications on mental health, post-traumatic stress and medical trauma, grief and bereavement, and survivor's guilt. In addition to these rankings, the survey also gathered over 3,000 open-ended comments. These responses were coded by clinical researchers working in teams with a fantastic group of adults with CF and CF parents. Here you see an example of one survey response included in the qualitative analysis. This member of the CF community was curious to understand how parenting practices might influence the experience of growing up for a child with CF. Our mental health research prioritization work reinforced the principle that there are many pieces to the mental health puzzle. Depression and anxiety have been important initial areas of focus and remain a top priority. However, many equally important topics are still understudied. Ultimately, the CF Foundation identified the 6 areas of focus for CF mental health research shown here. Next, I'll take you through examples of ongoing studies that highlight these areas of focus. Just as with other CF therapies, there is a pipeline of mental health interventions that are being developed, piloted, and rigorously evaluated, with the goal to make them widely available. Medication is an effective treatment option for depression and anxiety. Here, however, I'll focus on the remarkable growth of research on CF-specific psychological interventions designed to prevent and treat depression and anxiety. There are multiple programs at various stages in the research pipeline. Several of these programs are targeted to adults. Others are meant for adolescents, young adults, or children and their parents. Some, like Tactic and Uplift, are designed for a virtual group format. All can be delivered through telehealth to enable broad reach. These interventions draw on well-established therapies. The effectiveness of cognitive behavioral therapy, abbreviated as CBT, and related models like acceptance and commitment therapy, known as ACT, is supported now by hundreds of meta-analyses of randomized trials. What distinguishes the interventions in this pipeline is that they build on these evidence-based approaches by incorporating the input of the CF community to make sure that they address the specific needs of people with CF. We just saw that multiple research groups are doing exciting work to develop CF-specific mental health interventions. led by investigators including Deborah Friedman, Marika Verclay, CJ Bathgate, Virginia O'Hare, Abby Rosenberg, Mike Schechter, and Frida Liu. Today, though, I'm going to focus in on CF-CBT, which is the program I know best and the one which is furthest along on the pipeline, crossing into the phase of system-wide implementation. Now, some of you may be wondering, what exactly is cognitive behavioral therapy? CBT is a structured psychotherapy that emphasizes the relationships between feelings, thoughts, and actions. A basic principle of CBT is that learning strategies to change how we think and behave can lead to welcome changes in how we feel and how we cope with difficult situations. CF-CBT was designed to be integrated into CF care and can be done in the inpatient or outpatient setting, in person, or by telehealth. It's now available in several languages and in versions adapted for different populations and systems of care. CF-CBT addresses a number of skills that are key to maintaining physical and mental health. CBT teaches relaxation skills that reduce the physical impact of stress, as well as adaptive thinking skills that protect against unhelpful or distorted thoughts that can creep up when we're under stress. The CF-CBT program also teaches specific strategies that have been shown effective to reduce depression and anxiety and increase resilience, including ways to break the vicious cycles that can develop when we become isolated, avoidant, or less active, and how to work toward improving or maintaining health. Here you see a reflection by an adult with CF on what was important to them about completing the CF-CBT program, including being able to take active steps to manage their medical anxiety. On Thursday, Dr. Deborah Friedman presented outcome data from our randomized, waitlist-controlled prevention trial of CF-CBT in adults with CF with mild depression and anxiety. We found that adding 8 sessions of CF-CBT to usual treatment resulted in a huge improvement in coping self-efficacy. The CF Coping Self-Efficacy Scale measures confidence in being able to manage the challenges of living with CF. Specifically, it asks how certain you are at the moment that you can do things like help yourself feel more relaxed, be compassionate and forgiving with yourself, recognize when you're being too hard on yourself, manage stress effectively, and balance managing CF with still having fun in your life. Why is coping self-efficacy important? Well, in studies of people with chronic illness, coping self-efficacy has been shown to predict both immediate and long-term improvement in depression and anxiety. Coping self-efficacy is also associated with improvements in health-related quality of life and in physical symptoms such as pain and fatigue. This points again to the strong links between physical and mental health. These results demonstrate that learning relevant skills that are based in cognitive behavioral principles can foster resiliency for people living with CF. As I said when I showed the pipeline of CF-specific mental health interventions, the ultimate goal of developing and testing programs such as CF-CBT is to achieve broad reach. Last year in Philadelphia, 66 CF clinicians completed CF-CBT training at our NACFC mental health special class. This February, we're holding another 8-hour training, this time in a live virtual format. If you're a CF clinician working with adults, you can request additional information about CF-CBT training using the QR code you see here. In addition to training for members of the CF care team, we'd like to understand what else CF centers need to provide evidence-based mental health care in a sustainable and equitable way. The CF-CBT clinicians across the US and Canada who are participating in our CF-CBT implementation trial are helping us evaluate best practices that can increase access to CF-CBT for adults with CF, such as translating the CF-CBT workbook into Spanish and providing ongoing consultation to clinicians as they roll the program out at their center. Clinicians who complete our CF-CBT training on February 7th will become eligible to contribute to these efforts by joining the second wave of our implementation trial. Understanding more about the relationships of physical and mental health is one of the areas of focus for CF mental health research. Just as mental health is being routinely integrated into CF clinical care, mental health outcomes are increasingly being integrated as a critical piece of comprehensive CF research studies. One good example of this is the ENHANCE study, led by Paul McNally and Jane Davies. ENHANCE is a large, multi-center observational study of children with CF starting from infancy, which is just getting off the ground in Ireland and the UK. Given advances in our understanding and treatment of CF, the way CF manifests in young children is likely to change significantly in the next decades. ENHANCE will look at lung, liver, and pancreatic disease, but also mental health. Attending to children's mental health is fundamental, especially since preventive care can set the stage for continued well-being throughout life. Because this mental health care data from ENHANCE will be just one component of a broader study, it will also be possible, for example, to examine relationships between depression and GI symptoms, inflammation, and the microbiome. HOPE-CF is another study that capitalizes on the synergy of a research model integrating physical and mental health. In this case, to explore the impact of becoming a parent on the lung health of adults with CF, and especially the impact of modifiable factors such as depression, parental responsibility, and stress. Principal investigator Tracy Kazmersky and many of her co-investigators are members of SHARING, the CF Foundation Sexual Health, Reproduction, and Gender Research Working Group. The CF community has expressed strong interest in mental health as it relates to sexual and reproductive health and family building. As people with CF live longer and fuller lives, it's essential to foster healthy relationships and support the whole family. Another topic of high interest in the modulator era is the impact of CF management on mental health. WellMe was a large national survey deployed in the summer of 2022. Adults with CF and parents of children with CF were asked, have you or your child experienced changes in the following areas since starting a modulator? Here I'm showing only those adults and children who were taking elexacaftor, tezacaftor, ivacaftor, or ETI for short, at the time the survey was completed. In blue, you see the percentage who reported an aspect of well-being was somewhat or much better. In gray, those who experienced no change, and in pink or red, those who felt somewhat or much worse after starting ETI. People with CF taking ETI overwhelmingly reported that their overall health and quality of life became somewhat or much better. These benefits are, of course, not shared by those who are not eligible for currently available modulator therapies or do not have access, disproportionately impacting people with CF who identify as racial or ethnic minorities. When we turn to WellMe data regarding mental well-being, however, a different picture emerges. A subset of people reported that since taking ETI, they experienced worsening mental health symptoms, such as anxiety and depression, feelings of irritability or agitation, trouble thinking clearly, and disrupted sleep. Beyond the possibility of coincidence or pandemic-related stress, there are several reasons that might be, including psychological and existential reactions to starting a potentially life-changing therapy, drug-drug interactions, or individual differences in drug metabolism. The fourth possibility is that changes in mental health represent direct effects of the modulator on the brain. What might that look like? Well, maybe something like this. Clearly, it's complicated. One thing we know is that the CFTR protein is found not only in the lungs, but also in other parts of the body, including nerve cells within and outside the brain. I just want to stop here for a minute and thank Dr. Mike Van Elzacker and one of the clinical research coordinators in his lab, Dina Sadi, for donating her brain to create the impressive MRI image in the bottom right corner of the figure. We always knew that research coordinators were super brainy, and now we finally have the evidence to prove it. Yay, research coordinators. But seriously, we all know that nothing would ever get done without our amazing research coordinators. And of course, the individuals with CF and family members who dedicate themselves to participating in research. Now, although the role that CFTR plays in the brain is uncertain, it is possible that taking a CFTR modulator might change how the brain functions. For example, modulators bind to various neurotransmitter receptors and transporters that are important in emotion regulation. The GABA-A receptor, which plays a pivotal role in mental health, is a ligand-gated chloride channel. and neuropsychiatric changes could be driven by modulation of CFTR and chloride transport within the brain. Although we've come a long way, we still have many unanswered questions about how CF impacts mental health, how mental health impacts living with CF, and how all of this is shifting in the era of CFTR modulators. We are committed to carrying out the rigorous research necessary to learn more. As you see here, over the past decade, the CF Foundation has made a substantial investment in mental health infrastructure and research. Earlier this year, the Therapeutics Development Network founded PRIME, the Prioritizing Research in Mental Health Working Group. Working in concert with the Mental Health Advisory Committee, the mission of PRIME is to advance our knowledge of mental health conditions in the CF population throughout the lifespan and promote clinical and translational research that will improve the prevention, diagnosis, and treatment of mental health complications of CF. Mental health affects everyone, including CF care team members, which Shaina Blair, a clinical social worker, will discuss in the third portion of this plenary. Mental health is sometimes hard to see or understand. We ask people with CF, their family members, and CF care team members to answer from their own perspectives. What is mental health? Now, let's hear their voices.
For me, mental health is about recognizing that my state of mind is just as important as my physical health, my social well-being, giving myself the time and space to acknowledge my feelings, to sit with them, to truly process and validate. And it's about continuing to do this over and over, just the same as we spend this time on our physical health.
As a physician, I was taught to keep an emotional distance from patients until I fought my way through postpartum anxiety that was so vivid and terrifying that I now actually feel compelled to share it with some of my postpartum patients. When I see them in clinic and they're brave enough to admit that life with their newborn isn't all sunshine and rainbows, I ask for permission to give them a hug, and then I share my story. I disclose that despite my training, I did not recognize postpartum anxiety when I was going through it with either of my children. I tell them how I passed all my postpartum screening tests, lying because I knew what answers were expected. And then I tell them about the pain and horror that I suffered for 2 years of my life, because I want them to see that it is common, that it can affect anyone, that they too will survive this, and that they don't have to suffer in silence the way I did.
Mental health is being mindful of my anxiety and stressors related to CF. It means I take an active role in my child's care, but also understand there are aspects I cannot control, and find peace in knowing I'm doing everything in my power to ensure my daughter thrives.
Mental health is seeing a psychiatrist and a therapist to deal with the trauma of being slowly destroyed by a chronic illness and of going through pain and fear from a young age. Mental health is being able to share with medical professionals that you're sad a lot, that you think about dying a lot, without worrying that it will affect my care in a negative way.
As both a CF and an ICU doctor, I continually play a part in human suffering, death, truly painful and awful situations, and it still gets me where it hurts every time. But the sorrow and pain I feel are merely reminders that I have not yet lost that part of myself. Have no shame in tears. Seek support from your colleagues and provide it in return. Recognize when you are empty and take the time to refill. Don't be afraid to connect with your patients on a deep level. Not only do they need that connection, you need it too.
At the beginning of COVID, when everything shut down and there was so much uncertainty, we were all working from home. My kids were doing school from home. My husband was teaching 5th grade from home. And I remember talking to my patients who were scared and uncertain and worried about work and money and health and everything, and feeling like I had no idea how to support them because I didn't know how to support myself. I started an antidepressant for the first time in my life, and it really helped. It helped me get through that time. But it's still an ongoing challenge, and trying to be okay with that and know that that's okay, and that's, just part of life and always will be.
Mental health is health. It exists on a spectrum, and it can move along that spectrum depending on what's going on in our lives. When my mental health is good, I'm able to be a really present and patient mother. I'm a supportive partner to my husband, a sensitive yet boundaried friend. When my mental health is suffering, I'm unable to show up as my full self. Not for lack of wanting to, but like having a broken arm limits your ability to function, so does impaired mental health. Mental health requires patience, care, and attention, just as much as other kinds of health.
It's incredibly moving to hear these experiences from our community, shared with honesty and courage. In the journey toward mental health, we are not alone. As a CF care team member of over 13 years, I'm pleased to focus on care team well-being in the final portion of today's session. These are my disclosures. CF care team well-being matters. Team members offer unique knowledge, experience, passion, and commitment. In partnership with people with CF, care team members are essential to delivering innovative clinical care and leading research to improve physical and mental health. A common strength among CF programs is cohesive teams ready to roll out new processes. Dr. Smith highlighted team members showed incredible resourcefulness as we implemented the mental health care guidelines and met new challenges during the pandemic. Yet team members are human too. We are vulnerable to chronic stress, fatigue, and burnout from working in systems which can be simply unworkable. As people in caring professions, we are motivated by ideals like selflessness, loyalty, and stoicism. But these very ideals may compete with prioritizing self-care. To tip the scale toward resilience, we need regular opportunities to foster well-being. Prior to COVID, half of healthcare workers experienced burnout or a diagnosed mental health condition. People of color, women, and low-wage earners employed in healthcare are disproportionately impacted by stress in the healthcare workplace. A recent survey of almost 2 million people showed that the risk of suicide was higher for healthcare workers. This drives home U.S. Surgeon General Dr. Vivek Murthy's call to action to confront the drivers of burnout, particularly at governmental and organizational levels. We are learning about challenges specific to the CF professional community. In a survey this year, 53% of CF social workers reported uncertainty about remaining in their position. For those managing large caseloads, burnout was cited as the #1 reason for plans to leave. CF team members are more likely to be satisfied and stay with their teams when their roles are protected and supported by leadership. In mental health care implementation, we learned that centers whose mental health coordinator, either a social worker or psychologist, had more years of experience working there, reached a higher level of integrated care and services. This iterates the value of longevity in our teams and its connection to patient care. While the experience of burnout is personal to the individual, burnout is not a result of weakness or lack of personal resilience. Healthcare worker burnout is a result of factors in societal and organizational systems in which team members function. Care team members both witness and potentially themselves experience societal inequities such as stigma or barriers to accessing care, which are often higher for those belonging to marginalized groups. Administrative burdens and other system process issues can impose on the flexibility needed to provide relationship-focused care. When the burdens of delivering care conflict with one's core reason for being in a helping profession, care team members may experience moral distress. A respiratory therapist quoted here reflects this disconnect that impacts both sides of the caring relationship. Repeated workplace stress causes a heightened state of physiological arousal shown in these peaks. When stressors are so frequent that they don't allow opportunity for recovery in between, this becomes the new normal, creating potential for stress injuries. These can be precipitated by trauma, such as exposure to difficult situations, grief and loss, moral injury, and wear and tear from working long hours and managing large caseloads. When chronic stress is normalized, team members are less likely to recognize conditions like depression and trauma in themselves. Burnout involves 3 interrelated dimensions. The first dimension is sustained exhaustion, followed by detachment and cynicism and interpersonal workplace interactions, then reduced professional confidence and effectiveness. Without intervention, this process continues in a vicious cycle. Compassion fatigue and vicarious trauma accelerate burnout. Hyper-intellectualism, or staying in our intellect in an unbalanced way, alters awareness of the physical and emotional signals of stress. When we keep ourselves numbed out on overworking or cynicism, we don't have an accurate internal gauge of our needs. Slowing down to notice the impact of stress on our mind, heart, body, and spirit is an act of self-compassion. If your compassion does not include yourself, it is incomplete. A burnout screening tool can help us tune in and better understand our stress reactions. The Professional Quality of Life tool has been validated for use in those in helping professions and is freely accessible. The ProQOL identifies burnout, compassion fatigue, as well as compassion satisfaction, an aspect of resilience. Provides a report of your screening results with personalized, evidence-based self-care tools. Stress First Aid was developed to help healthcare workers help each other. It involves a core function, check. We first check in with ourselves, then notice and respond to signs of stress in coworkers. We can facilitate this organically with a spirit of teamwork and support. The key is to check in with regularity. This may look like finding a space for conversation, asking about concerns, and being intentional about checking in during times of known difficulty. Open inquiry and acknowledgement reduce stigma and normalize our human need for connection. As we collaboratively work to build an ecosystem for resilience, let's remember mental health is more than the absence of mental disorders or burnout. It's a state of well-being. Care team members are fortunate to be among individuals and families who demonstrate resilience in inspiring ways every day. A recent study by White and colleagues found that despite the challenges of living with chronic illness, people with CF tend towards a perspective of optimism and hope. A lens of hopeful optimism is a welcome shift from the depletion and cynicism of burnout. Perhaps in a parallel way, our patients and families, through their many strengths, teach and care for us. Now I will move through the PERMA model and its 5 domains of positive functioning. I will highlight how each well-being component is applicable for the CF professional community. Positive emotion can be cultivated. In a study using daily gratitude practice as part of a broader resilience-building intervention, adult CF team members at UVA experienced improvement in stress and work-related exhaustion. Team members used a practice known as 3 good things individually, then share gratitude for 5 minutes at the beginning of team meetings. Personally, I'm grateful seeing the faces of friends and colleagues in the audience. What about you? Perhaps you can identify one thing you're grateful for today. Mindfulness is a practice of awareness and engagement in the present moment with an attitude of openness and compassion. Engagement is the opposite of detachment, primary construct of burnout. At the Cincinnati Children's CF program, CF team members participated in a series of mindfulness-based cognitive therapy sessions. After a month, team members reported improvement in levels of stress and empathy and less detachment. Those who continued to practice mindfulness showed sustained benefits after 15 months, with additional improvement in depressive symptoms. Again, relationships are a primary strength of the CF interdisciplinary team structure. Yet disconnection remains an area of vulnerability for all of us at a time when pervasive loneliness has been declared a public health epidemic. In a review of evidence-based burnout prevention programs implemented at the organizational level, all included an element of formalized, discipline-specific peer support. The CF Foundation offers a number of regular peer connection opportunities for all disciplines. Connecting with the sense of meaning. In a survey of 220 CF research coordinators, over 90% report a sense of belonging in their CF research centers and that they're making a difference in their work. Similarly, participants in last year's Mental Health Coordinator Mentor Program described the value of being a peer mentor by noting, "It's so meaningful to build connection and give back." As we near the end of this year's conference, I hope you're feeling accomplished in your individual and team contributions to research and care. Certainly, it's an accomplishment being together in this plenary, recognizing and celebrating a culmination of important work in mental health. We've acknowledged risks and challenges to team member well-being, and I hope we continue to realize that tipping the scale toward resilience is indeed a community commitment. As you reflect on that commitment and the tools you've heard about today, I invite you to consider at least one tangible action you can take toward well-being personally and as a team. For those team members whose primary role is supporting mental health at your center, I'll offer you an easy first step, and that is connecting with a mental health coordinator consultation group. As we hold our well-being commitments top of mind, it is my pleasure to introduce Ashley Ballou-Bonnema. Diagnosed at 1 month old with CF, Ashley is a passionate advocate for the CF community. As a professional vocalist and the executive director of Breathe Bravely, Ashley has developed an innovative approach to CF through harnessing breath and singing. We're grateful for Ashley's presence on screen as she invites us to fully engage and connect with the power of breath.
I feel extremely privileged to be sharing some breath exercises with you today from a program I developed called Singspire, which combats the effects of cystic fibrosis through the art of singing. At the core of the program is the art of breathing. And that is a gift to each one of us, regardless if you have CF or you've dedicated your life to the cause. I want you to start by closing your eyes. I want you to quiet yourself, and I want you to give yourself the freedom to breathe. I want you to take a breath in through your nose. And I want you to ask yourself a question. Is this the first time that you've thought about your breath today? This week? What is it telling you? Is it telling you to let go of all of the weight of the week, of your day? I want you to take a breath in through your nose, and I want you to feel where that tension is in your body. I want you to allow yourself the freedom to breathe. What's gonna happen is I'm gonna count to 6. You're gonna hear me snapping. And then you're going to shh, like you're hushing a baby. And you're gonna do that for 12 counts, okay? And you're gonna do that 2 times in a row. With every breath that you take in through your nose, I want you to be mindful of that expansion of your body. Is your rib cage expanding? Are those intercostal muscles flexible? Is that diaphragm descending? Are you pulling that air into the bottom parts of your lungs? push your air out. Take a nice easy breath back in before we start. In for 6, shh for 12 times 2. Push your air out again. And in, 2, 3, 4, 5, 6. Shh. In. Our breath is one of our greatest advocates. You have the freedom to use it every single day. I want to leave you with one last breath cycle. You're going to take a breath in for 6, and you're going to pretend that you have a straw between your lips. And I want you to focus on how that's going to feel a little different than the shh that you just did. Be present within your body. It does not matter the amount of breath that fills your lungs. It is what you do with it that gives you the greatest life. So you're going to do in for 6 again, through a straw. If you need to, put your hand in front of your lips to feel that beautiful breath. So in for 6, for 12, okay? So push your air out. And in, 2, 3, 4, 5, 6, straw, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and in, 2, 3, 4, 5, 6, out, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. If you haven't already, open your eyes. I want you to take a breath in through your nose, and I want you to feel how grounded you are. That breath you just took is a gift for you too.
And what a gift that is. Thank you, Ashley. On behalf of Beth, Anna, and myself, we hope you've been inspired by seeing the progress and ongoing investment in mental health care and research. We hope, too, that you are reinvigorated and prioritizing your well-being. We invite you to continue the conversation on resilience and look forward to exciting horizons and improving our collective health and the lives of people with CF. Thank you. Now please welcome Mike Boyle to the stage to close the conference. Thank you.
Flip this up here. There we go. Well, thank you, Shaina and Beth and Anna and Ashley for this really important session. And we really look forward to supporting this and continuing to see the progress unfold in the months and the years ahead in this area. And this brings us to the close of our conference. It went fast, didn't it? It went really fast. But there's one thing these last few days have convinced me, and that is that there's really nothing like our CF community. I'm absolutely convinced after this meeting that we can accomplish things together. We can accomplish anything together, right? And so over these last few days, we've pushed forward and heard about innovations headed towards genetic therapies and better modulators than ever before. We've heard about novel approaches to address the challenges that people with CF still face every day. And we've heard about how essential it is to pay attention to the overall well-being to individuals with cystic fibrosis and ourselves to make sure that we're at our best. I think also along the way, we absolutely experienced those 3 C's I mentioned at the opening plenary: the cutting-edge science, the caring for people, and the collaboration. What a privilege it is to be part of this CF community. I want to just take a moment to thank all of you for making this a great few days. Thank you to everyone who's contributed to making this a special few days. So grateful for your work. I also want to ask you to join me to give a special thanks to the CFF meetings team, who just did a remarkable job of putting this meeting together. Now, to close us out, those of you who are NCAA basketball fans know that they always end their NCAA tournament with a highlights video that they call One Shining Moment. And we want to start to do this and close this year's meeting with highlights of some of those shining moments from our time together these past few days. And so I hope you enjoy it. I hope it gives you greater appreciation for what we have as Team CF. and I look forward to seeing you next year in Boston.